Dr. Pecchia, it's all you.
Okay. Lauren, would you like to start off, and then I'll pick up after your introduction, and welcome.
Perfect. Good morning, everyone. Today we have a really exciting presentation today. Actually, we have a lot of speakers. We have Dr. Good and some medical students, as well as some neurologists, Dr. Bernstein and Sid Kern. And we're going to be going over some neurological manifestations of COVID-19.
Thank you, Lauren. And Lauren is one of the directors of our global grand rounds of global offsite care, volunteering and doing a fantastic job. Thank you, Lauren. Welcome to you all for the special edition of Global Grand Rounds on motor and sensory neurologic manifestations of COVID-19. I'm Dr. Gregory Pecchia. I'm a geriatrician and director of telemedicine and academic innovation at Western University of Health Sciences, which partners with global offsite care and for the production of these global grand rounds. And in my role as medical director of global grand rounds, co-medical director, just wanted to handle a few housekeeping items, a brief word about our ACCME accreditation requirements to ensure that we can get some 1A credits for this in future medical education resources. So with that, any of our speakers who so choose can reiterate assurance that nothing that is presented today has a conflict of interest for selling or distributing healthcare products. So that said, let's start off right, as they say, by an introduction of Scott Reed. Mr. Scott Reed's a poet in residence who's hosted by Offsite Care, Inc., the UC Davis Master's Degree graduate in English. His most recent publication was a poem entitled Discourse on Life in the Hive and Why, and in the Why to These Rocks anthologies. Currently the adjunct instructor of a memoir writing class presented by the Santa Rosa Junior College for older adults. That's up in Northern California, Bay Area, and as an instructor of poetry and medicine for third and fourth year medical students, including those with us today, and presenting at Western University School of Medicine, College of Osteopathic Medicine, and both campuses, Pomona and Oregon. So with that, Mr. Reed, the floor is yours.
Dr. Reed, I need you to unmute, I think.
Always a good idea to check the muting button. 19 seconds into my presentation and I'm just getting unmuted. Yeah, it's a pleasure to have the opportunity to address you all. And this morning we'll be listening to the poem called Fish by Elizabeth Bishop. Now, when I'm tasked with this privilege of selecting a poem to match the presentation, motor and sensory neurological considerations, I have to think now, what sort of poem would fit nicely with this? Well, if you come to Northern California, from the Northern California area, and you go into a restaurant, sommeliers often are tasked with this similar issue of trying to find a suitable pairing of what sort of a wine might go well with a certain dish. So would we like a Chardonnay this morning with some chocolate, or, well, maybe a little early for Chardonnay. It's a similar process. So what poem would fit with this particular topic that we're considering today? And Elizabeth Bishop's Fish poem almost immediately came to mind for a number of reasons. One of them is It's a straightforward poem. It's a narrative poem that is describing the process of catching a fish. And then essentially the body of the poem is a profusion of sensory images. So in a way that this poem is a kind of a sensory examination of the process of catching a fish. And also the speaker of the poem is providing a sensory examination of the fish. What I've loved about this poem for a number of years is the use of the five senses: sight, sound, touch, taste, and smell. And in some places, the poem combines them. So while you'll hear a few images, I'll just point them out before I read the poem for you. At the opening here, she talks about bringing the fish close to the side of the boat. And she says that he hadn't fought at all. He hung a grunting weight, battered and venerable. And I'm thinking, grunting and weight. Well, grunting and weight is a combination of both a tactile and an auditory image. A little bit lower, you'll see a line that says, he was speckled with barnacles, fine rosettes of lime, and infested with tiny white sea lice. There is a combination of tactile, visual, and gustatory imagery. And then, of course, at the end of the poem, there are some references to the intuitive, the sense of intuition, this fine-haired beard of wisdom trailing from his aching jaw. The observation that all these broken lines are like a beard of wisdom. And then we looked at this during the a poetry and medicine rotation, and it was pointed out that this poem, in a sense, mirrors the doctor and patient exam. Dr. Good suggested to us in a reading of the poem was that sometimes the doctor just needs to let the patient go. So I'm into my comments time, and here's the poem by the Elizabeth Bishop called The Fish. I caught a tremendous fish and held him beside the boat, half out of water, with my hook fast in a corner of his mouth. He didn't fight. He hadn't fought at all. He hung a grunting weight, battered and venerable and homely. Here and there his brown skin hung in strips like ancient wallpaper, and its pattern of darker brown was like wallpaper, shapes like full-blown roses stained and lost through age. He was speckled with barnacles, fine rosettes of lime, and infested with tiny white sea lice, and underneath 2 or 3 rags of green weed hung down. While his gills were breathing in the terrible oxygen, the frightening gills, fresh and crisp with blood that can cut so badly, I thought of the coarse white flesh packed in like feathers, the big bones and the little bones, the dramatic reds and blacks of his shiny entrails, and the pink swing bladder like a big peony. I looked into his eyes, which were far larger than mine, but shallower and yellowed, the irises backed and packed with tarnished tinfoil, seen through the lenses of old scratched isinglass. They shifted a little, but not to return my stare. It was more like the tipping of an object towards the light. I admired his sullen face, the mechanism of his jaw, and then I saw that from his lower lip, if you could call it a lip, grim, wet, and weapon-like, hung 5 old pieces of fish line, or 4, and a wire leader with the swivel still attached, with all their 5 big hooks grown firmly into his mouth. The green line, frayed at the end where he broke it, 2 heavier lines, and a fine black thread still crimped from the strain and snap when it broke and he got away. Like metals with their ribbons frayed and wavering, a 5-haired beard of wisdom trailing from his aching jaw. I stared and stared, and victory filled up the little rented boat, from the pool of bilge where oil had spread a rainbow around the rusted engine, to the bailer rusted orange, the sun-cracked thwarts, the oarlocks on their strings, and gunnels, until everything was rainbow, 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 and I let the fish go. Thanks for listening, everyone, and I look forward to hearing your presentations. Thank you, Dr. Pecchio.
Thank you, Mr. Reed. Much appreciated. Thank you for that. Moving forward on a tight timeline, I'd like to introduce our 4 students and clinicians who will be speaking with them today on today's presentation. First, we have Kunwoo Lee from Comp Northwest Western University, who is applying to physical medicine rehab as 4th-year student. Grew up in Claremont, California, attended Occidental College for his undergraduate degree in cell and molecular biology, and enjoys his free time playing basketball, volleyball, and traveling. Patricia Nguyen, also from Comp Northwest Western University in Oregon. Hometown is Tigard, Oregon, outside of Portland, and got her undergraduate degree in Spanish language and literature, as well as medical anthropology from Creighton University in Nebraska. She'll be pursuing pediatrics and intends to serve within rural primary care. Tatiana Getman, 4th-year medical student at Western U Comp in Pomona. She's originally from the Bay Area and earned her BS in biological sciences at UC Santa Barbara. Go banana slugs, Tatiana. She will be pursuing internal medicine with the goal of becoming a hospitalist who helps her future patients feel comfortable and cared for when at their most vulnerable. Our 4th student presenting today is Solomon Alvarado, also a 4th-year medical student at Western University in Pomona, applying to emergency medicine. Raised in Burbank, Greater LA, and obtained a BS in biology from UC Riverside. He enjoys hiking and spending time with his family. Dr. James Good, who most of you know. He's an emeritus professor of medicine at UC San Francisco, an esteemed pulmonologist in the Greater Bay Area, and a serial medical entrepreneur, founding, in fact, Offsite Care Inc., which generated the nonprofit Global Offsite Care, who many of you know hosts these Global Grand Round sessions. He's been in practice for at least 5 decades. Correct me if I'm wrong, Dr. Good, but probably 6 decades, who brings us together today in his role as the medical director of Offsite Care Inc. that pioneers in tele-intensive care across Northern California and now through the Western states. He also helped found the nonprofit Global Offsite Care, which, as you know, provides support for telemedicine for the underserved. And thank you, Dr. Good, for leading on this today. Our consultants today will be Dr. Allan Bernstein, a board-certified practicing neurologist in his 5th decade of medical practice, previously having served in a variety of clinical and leadership positions with Kaiser Permanente Medical Group in the East Bay, as well as in organized medicine in Greater Sonoma County. He is an accomplished clinical investigator with a long list of research publications to his name. He's currently providing neurology consultation coverage for hospitals in Healdsburg and Sebastopol, California, in the north of San Francisco in the Sonoma County area. He also provides teleneurology services for a number of medical groups and continues as UC San Francisco Assistant Clinical Professor of Family Medicine in Santa Rosa. Finally, we have Dr. Sidney Kern, also board certified in neurology and affiliated professor of neurology and UC San Francisco School of Medicine, where he is emeritus clinical professor in the Department of Family and Community Medicine. He's also extensively trained in acupuncture and herbal medicine and their application in the practice of integrated medicine, having been the chairperson of the Sonoma County Medical Association's Integrated Medicine Forum. Welcome, Drs. Good, Bernstein, and Kern, and thank you for being with us here today to walk us through how telemedicine in a multi-presence format can improve access to specialty care in remote locations, while at the same time, as we're doing today, providing a globally scaled simultaneous teaching platform for clinicians and training. So back to our students and take it from here.
All right, good morning, everybody. So we have actually been working with a few patients in the ICU through Teladoc. One of them was supposed to show up for today's presentation, but we'll just mention the physical exam that we were able to complete with her yesterday. Just briefly, she's a 41-year-old female who was a COVID patient. She had a pulmonary embolism and upper respiratory infection, and she had been encephalopathic for 4 months. And she was diagnosed with critical illness myeloneuropathy. So for this sensory exam that we did yesterday, we were able to have a bedside nurse practitioner who was able to test her visual fields. So he used his hands and had her point. For the part where he asked her, can you read this? He actually used a Coke can or a soda can and held it in front of her and asked her to read the front line. For hearing, he was rubbing his fingers next to her ears, and then she would say whether or not she could listen to them. For smell, he held a cup of coffee next to her nose and she told us what it was. For taste, we put a little bit of salt in her mouth and she told us what that was as well.
And the next parts of the sensory physical exam that we thought was pertinent was touch. And so we wanted to test the ventral spinal thalamic tract. And so we asked the nurse practitioner to have a special brush and brush it across the V1, V2, and V3 dermatomes bilaterally. And then we also tested the C6 and the L3 dermatomes on the thumbs and across the knees. Next, we wanted to test proprioception, which is the dorsal column tract. And so we had the NP move the patient's thumb from neutral to up and down and see if the patient could tell which position the toes and thumbs were in. And finally, we wanted to test pain. And so we had the NP do a light to deep palpation of the abdomen in all 4 quadrants. And so with this patient, even months post-COVID exposure, she did have significant positive results on the physical exam. With the visual exam.
Yeah, she had a diminished left visual field intact. She also was having trouble hearing with her right ear.
And for touch, her sensation to light touch was fully intact, but her proprioception was not intact in both toes bilaterally. And otherwise, the physical exam was normal. And we will pass it along to our motor exam.
I believe in the order of the itinerary, we were going to do Dr. Kern's. Is that a presentation?
I apologize, yes.
No
We
worries.
will
I was
pass
just making sure. Okay, perfect.
Oh, you ready for me to speak? Oh, okay. You want to bring up the slide? Oh, great. Okay. Is this the new deck?
Yes, this should be.
Thank you. Well, it's a pleasure to be here. I like the rings and rings of rainbows at the end of that poem, and it was very uplifting at the end, despite the fish. Well, because of the fish, I suppose. So I'm going to talk about sensory neuropathy and pain in COVID-19, and then finish with treating it with natural substances. Next slide. Thank you. So, as you know, coronaviruses can cause a common cold, but the real pathogenic ones that have caused SARS and MERS are currently causing SARS-CoV-2, COVID-19, although the latest Omicron is quite mild, but the Delta was not. And the one prior to that was not either. Most of you may know this, but the virus has spikes all over its surface, and the tip of the spike connects to the angiotensin converting enzyme 2 receptor on the human body. It occurs in the vascular endothelium, and that's particularly important when we come to the nervous system. It also attaches to glial cells and neurons, as well as the lung epithelium. Of interest is that the dorsal root ganglia has ACE2 receptors. The dorsal root ganglia contains the cell bodies of the sensory roots that go out to the limbs, all the way to the distal aspect of the limbs. I just want to say, it's a very good sensory exam, but if you're going to look for peripheral neuropathy, you really want to test light touch and pinprick at the extremes of the limbs, the hands and the feet. Let's go on. About 36%. No, I'm sorry. The same slide. About 36% of COVID-19 cases have neurologic manifestation. Most of them, 25% of the cases involve the CNS, and 9 to 10% involve the peripheral nervous system. And we're going to talk about the peripheral nervous system today, not the central nervous system. Okay, thank you. Yeah, we can skip the sensory exam. There's different types of peripheral neuropathies in COVID-19. The majority actually is mononeuropathy multiplex, which is up to 16% of patients with peripheral neuropathy. Mononeuropathy multiplex just means multiple single nerves. Mononeuropathy multiplex is most likely vasculitic. As most of you know, the vessels are involved with the COVID-19, the SARS-CoV-2 virus. Invades the endothelium, clots are formed, and so that may be the mechanism whereby multiple single nerves get affected, and mononeuropathy multiplex can be painful. The next one is critical illness neuropathy, which is not uncommon in the ICU, and it's up to 10% of patients in COVID-19 with peripheral neuropathic complications. They do not have significant pain. It's not on the slide. I wanted to, since this patient, I believe, has critical illness neuropathy, there's no well-defined pathogenesis of critical illness neuropathy. It appears that probably the main underlying mechanism is redox, oxidative stress. If you measure the redox potential in ICU patients, it goes down as the length of stay or the criticality of the patient goes up. What that means is that you have more and more free radicals, and free radicals do damage to proteins wherever they find them. Other proposed mechanisms is microcirculatory abnormalities, which could be caused by the COVID-19 invasion of the endothelial cells of the vasonovorum, the blood vessels that invade the nerves, metabolic derangements, and then something called channelopathies. The way nerves work is that along the nerve, there's these channels that sodium and potassium can go in and out, as well as calcium. And if these channels do not work, the nerve will not conduct an electrical signal. So that's also a proposed mechanism. A bioenergetic dysfunction, basically that refers to the loss of ATP in the nerves. This is not specific for COVID-19. Critically ill patients lose their defenses against oxidative stress. They also have a depletion of their own ATP. And so some of these there are remedies that are proposed for critically ill patients, whether it's COVID-19 or not, to raise their oxidative defenses. There's also a critical illness myopathy of the muscles, and the muscles can become sarcopenic. And then there's the neuropathy myopathy combination. Less common, far less common, is Guillain-Barré, 15 cases per 100,000, and that is painful. We'll talk a little bit about molecular mimicry, which is interesting to me. And finally, traumatic localized neuropathies. The prone positioning, which was common and may still be common, maybe Jim can comment on that. That can affect the brachial plexus. Chest tubes, tracheotomy can also cause damage to single nerves. The traumatic neuropathies tend to be painful. There's no specific epidemiologic evidence for what the prevalence is of this type of neuropathy. Okay, we go to the next slide. This is the sensory exam, and I think you all did it well. I would just want to emphasize that if you're going to look for, Guillain-Barré or intensive illness neuropathy, intensive care illness neuropathy, you want to really do pinprick in the toes, in the feet, light touch in the toes and feet, as well as vibration. Position sense, you did well. Just a word of caution, the sensory exam is subjective. The motor exam is objective, and it can become unreliable if you do it quickly. So the exam should not be rushed and must proceed efficiently. Okay, we can go on to the next slide. And anyone can interrupt me if they have any questions. I'm not going to spend much time here because initially I thought this was a COVID-19 Guillain-Barré patient. As I reported earlier, it's pretty rare. It's 0.3% approximately of COVID-19 patients. And as most of you know, Guillain-Barré generally follows infectious organisms like Campylobacter, Mycoplasma, Haemophilus, influenza, CMV, and EBV. The very interesting thing about Guillain-Barré is that molecular mimicry probably plays an important role. There are gangliosides, somewhat complex molecules, in the membranes of nerves and Schwann cells. Schwann cells are the insulating cells of the peripheral nerves. And there's an overlap between the antigens of the gangliosides and the antigens of the infectious agents. And so an autoimmune mechanism is set up. The body creates antibodies against the antigens of the infectious agents, and then they attack the gangliosides in the membranes of the body's own nerves. And that's one of the main mechanisms of Guillain-Barré. In SARS-CoV-2, they have measured anti-ganglioside antibodies. In addition to molecular mimicry, just the overall neuroinflammation and cytokine storm probably play a pivotal role in the onset and progression of GBS. Okay, we can go on to the next slide. Let's just talk about pain in Guillain-Barré, and then in general, there's the large myelinated sensory fibers, the nerve roots, and the small fibers. And each have a special quality to their nerve and as well as their distribution. Large myelinated fibers cause dysesthesia. Dysesthesia is pain with even light touch. Guillain-Barré, as you know, starts in the feet and legs and spreads to the upper body. But in my experience, the most problematic pain, and it's difficult to treat, is on the buttocks, on the low part of the back, and on the posterior aspect of the thighs. The nerve roots that are affected can cause pain in the low back that radiates the extremities or trunk. And small fiber, like C fiber sensory impairments called paresthesias, pins and needles sensation. Okay, the next slide. Thank you, Lauren. All right, so unless there's any questions about the spectrum of, I did not talk about the CNS, we're just focusing on the peripheral nervous system. I've picked a few natural agents that actually work at a molecular level that shows that they could be effective. And all the agents that I've picked have been historically used, like St. John's wort is probably at least a millennial old, the topical and probably the oral use of St. John's wort oil. One of the main constituents is hyperforin. And as a matter of fact, the modern usage of St. John's wort is for depression, but it's actually a nervine. A nervine is a middle-aged term for the Middle Ages of the history, not the patient. It's a lot of the herbal names come down from the Middle Ages, and they're sort of quaint. And anyways, St. John, the hyperforin is a nervine. It inhibits COX-1 and lipooxygenase, which make pro-inflammatory molecules. It also inhibits TNF-alpha and IL-6. As most of you, I'm sure all of you know, the cytokine storm, as it's called in COVID-19, involves interleukin-1, interleukin-6, and tumor necrosis factor alpha. And St. John's wort actually downregulates them. In addition, St. John's wort is noted to reduce neuropathic pain. The oil could be rubbed down in the painful areas. This could be used, in even here in the States, but in places where they don't have access to, I don't know if we have representation from Africa here on this lecture or not. I don't see, I saw it in the flyer, but in any case, these would be good remedies in urban, rural hospitals where they may not have access to GABA gel, for example, which is one of the topical pharmaceuticals. So that's St. John's wort oil. Alpha lipoic acid. Alpha lipoic acid is a very prominent antioxidant in your own body. It's also anti-inflammatory. It's both water and fat soluble in the body. It's not so in the lab, but it is in the body. It's essential to the performance of 5 enzymatic systems. It's a very important antioxidant, but it also inhibits TNF, IL-1, beta, and IL-6, and it also mitigates neuropathic pain. It can be put into a cream, and you can buy it commercially, and it can be applied topically. I also want to introduce gene transcription factors. These are molecules that turn on and off genes. NF-kappa beta is one of the prime gene transcription factors that turn on pro-inflammatory molecules. And alpha lipoic acid inhibits NF-kappa beta. Okay, thanks, Lauren. Next slide. So here's 3 more. Aloe vera gel. As most of you know, if you have a burn, you put on aloe vera. You can just cut the leaf and squeeze the gel onto your burn, and it works very well. It's analgesic, antioxidant, and anti-inflammatory. And it also inhibits TNF and IL-6, as well as inhibiting some gene transcription factors. Let's go on to magnesium. The nervous system, even though it's extremely complex, there are two main transmitters in terms of the amount of synapses present in the nervous system. The first one is glutamate, which is about 70 to 80% of all neurotransmitters in the central nervous system, and GABA, which is about 10 to 15%. And the rest are dopamine, serotonin, glycine, and so on. Magnesium, which can be absorbed topically in a cream, can block the NMDA receptor, which is the receptor for glutamate. And glutamate, in addition to being excitatory, is the main neurotransmitter for pain. GABA can also be applied topically, and it enhances local levels of GABA at nerve endings. GABA being the main inhibitory neurotransmitter, it inhibits the transmission of pain. Okay, go on to the next slide. Unless that's the last slide. Oh yeah, I don't want to leave out essential oils. Essential oils have been used throughout history, and it was first documented by Islamic writers in the 1100s. And they're really quite remarkable substances. I'm going to talk about 4 of them real quickly. Peppermint, it's an agonist on the GABA receptor and the glycine receptor. Glycine is also an inhibitory neurotransmitter. Now let's go on to rosemary essential oil. One of the main ingredients is 1,8-cineol. And for those chemists out there, it's a monoterpene oxide. 1,8-cineol has analgesic properties. It's also anti-inflammatory and antioxidant. And I think I'll skip the next slide. Okay, the next slide. Lavender, in addition to having a wonderful smell that is uplifting, it has terpenes, and the predominant terpenes are linalool and linalool acetate. Linalool is antinociceptive. Basically, it blocks pain, and it's attributed to the fact that it can stimulate cholinergic, opioidergic, and dopaminergic systems. I would think that the opioid receptors would be the main receptors that it stimulates to block pain. It also blocks the NMDA receptor for glutamate. Okay, so now we'll go on to clove essential oil. For those of you that have had any tooth pain, if you put a Q-tip in some clove essential oil and rub it on the tooth, the pain goes away. And I found it essential in the care of my teeth. The main ingredient in clove is eugenol. And eugenol is GABAergic. It stimulates the GABA receptor. The other interesting thing about clove oil is it inhibits voltage-gated sodium channels. And as I mentioned earlier, the channels which go from the outside to the inside of axons is where all of the ions go in and out. And that's how a action potential goes down the nerve. And if you can inhibit the sodium channels, the nerve will not conduct electricity. And so eugenol prevents conduction along pain fibers by inhibiting the voltage-gated sodium channels. Just real quick, the essential oil should be diluted in a carrier oil. Someone in the online or in an article had mentioned how concentrated they are. 1 drop contains 40 million trillion molecules. Okay, so that's if there's any questions. If not, you can go on to the next speaker.
Okay, thank you very much, Dr. Kern. I think in the interest of time, we'll go ahead and hold questions. So for those of you who have a question for Dr. Kern, we'll hold that to the conclusion. So with that, back to our students who will take us down the motor pathway of complications of COVID-19 and to be followed by Dr. Bernstein's comments on that. So the floor is yours.
Good morning, everyone. To reintroduce myself, my name is Tatiana. I do have to disclose that I have no financial relationships or conflicts of interest to disclose related to this presentation. So I had to tell you that first. So it's unfortunate that we were unable to see our patient today. We were originally going to see her at the bedside using telemedicine, and we've been seeing her throughout our rotation. She's made a huge leap from where she started to where she is now. Particularly when it comes to her weakness, her generalized flaccid weakness throughout. So we'll try to capture what we saw with her when we did the physical exam as best as we can. In general, when doing a motor exam, particularly with telemedicine, it can be pretty difficult, especially if the patient is in the ICU. So we want to try to utilize a range of minimal movements to facilitate communication. This can include forehead wrinkling, eye blinking, mouth movements, head or limb twitches. So we start off with eyes, and Solomon's going to take us away with that one.
Hello, good morning. My name is Solomon, and so yeah, starting off with the eyes, pupillary testing is very important. We assess cranial nerves 2 and 3. We can also use the H test with the help of whoever is helping on the floor to test for any ophthalmoplegia or nystagmus. And in the case of our patient, yesterday she had a normal pupillary response. There was no evidence of ophthalmoplegia or gaze palsy, and no nystagmus as well.
And then when it comes to speech, this can, again, also be difficult to assess in ICU patients that have many tubes in. But if the patient is able to speak, it's important to look for any signs of hoarseness or dysarthria in their voice. Bulbar function can be difficult to assess because many of these patients will have an ET tube in place, but despite the ET tube, we try to get a sense of tongue movement and pharyngeal reflex, and can also look at palatal rise if able to, and then take a look at tongue movement to look for any asymmetry or any deviation. In our patient, all of this was normal.
And next up, we wanted to check facial symmetry, assessing whether if one side of the face was weak. We looked whether it included the forehead or if it spared the forehead. We would have the patient raise their eyebrows, close their eyes, smile, frown, and puff out cheeks. And for our patient yesterday, facial symmetry was present and there was no evidence of weakness.
And then arguably the most important, looking at muscle movement or testing muscle strength. So this again can be difficult. Grading it isn't super necessary or important here. It's important to pay attention more so to patterns and then look for any proximal versus distal muscle weakness. You can take a look at neck flexion and shoulder abduction. That often gives a helpful guide to weakness of the respiratory muscles, particularly the diaphragm. Check for any presence of fasciculation or weakness in the extremities that can raise concern for motor neuron disease versus a more fatigable weakness could indicate a neuromuscular junction abnormality. And then in really important in ICU patients, weakness of the extremities, more so kind of a flaccid generalized weakness with sensory loss could suggest critical illness, neuropathy. If there's no sensory loss, could be more of a concern for critical illness, myopathy. In our patient, she had neck weakness. She had pretty much generalized flaccid weakness throughout. And it was difficult to tell if it was more so proximal versus distal, but there were definitely some proximal muscles involved.
And lastly, for our patient yesterday, we checked the tendon reflexes. It might be a bit more easy to check the bicipital and patellar reflex. And in the case of our patient, she actually had diminished reflexes throughout both upper and lower extremities bilaterally.
I'm sorry, what did you say?
For our patient yesterday, we checked the patellar and bicipital reflexes, and she actually had diminished reflexes in both.
They were intact?
Diminished.
Diminished.
Oh,
Okay.
diminished, sorry.
Okay. They were
Did she have
present.
did she have ankle jerks?
She did not.
Okay. Thank you.
And
Okay.
that concluded our motor portion of the exam.
Appreciate it very much, Solomon and Tatiana. That was an excellent review and presentation. And with that, our other visiting neurologist consultant, Dr. Bernstein, your comments, and looking forward to your perspective on the motor exam and motor complications of COVID-19. We have about 10, 15 minutes for you.
Okay, thank you. Following Dr. Kern is always difficult. He's got an incredible array of material. And you can tell his patients coming anywhere in the vicinity because of the aroma from all of the essential oils that his patients are using. That said, the key difficulty in the motor in COVID is stroke. That is the single most prevalent neuromuscular problem that these people get. There's a hypercoagulable state and they develop strokes. They have strokes at every age. There are children with strokes, there are young people with strokes. Certainly as the age goes up, strokes are the major marker. The motor exam is often your markers. Sensory exams are, as Sid pointed out, can be difficult, but should be properly done. Motor exams you can almost do from across the room on patients with stroke. Because as you approach the patient, you'll notice spontaneous movement. Is it symmetrical? Is it not symmetrical? Is their face symmetrical? Are they moving one side? Are they not moving one side? So a huge amount of your stroke assessment starts off with just literally walking around the patient and observing them. You don't have to touch them. You don't have to talk to them. You just walk around and look at spontaneous activity. Clearly somebody in an ICU, possibly intubated, is going to have difficulty assessing speech. If they're not intubated, you can determine their speech, which is their marker for tongue movement. It's your marker for pharyngeal symmetry. People with strokes involving brainstem have changes in their speech pattern. So the speech is in itself a motor exam, how they're doing it. What I like to consider is when your exam was excellent in terms of looking at the symmetry. One of the really interesting things you can do on somebody who's able to do it is if you ask them to raise one arm up straight out in front of them and just wait and see if they've got a wrist drop, i.e. a distal motor weakness, or a shoulder droop, which is a proximal weakness. And they have different meanings. And you can do this not just in hospitalized patients, but in any patient. It's a very simple test. Ask them to bring up one arm, bring up both arms, and watch if there's a droop. Is there a drift? Is there a movement? Is there a tremor? One of the markers in your exam is, have they got tremors? Have they got a Parkinsonian-like tremor? Have they got an essential tremor? Have they got a drug-induced tremor? Tremors are an important part of a motor exam. Rapid tremor, slow tremor. Parkinson's are slower, essential tremors are faster. Drug-induced tremors tend to be faster, and metabolic tremors, i.e. thyroid-related tremors, are a more rapid tremor. So you want to look for motor activity and looking at tremors. as Sid pointed out very nicely, people are in the hospital for a long time. They develop critical illness weakness. It's a generally diffuse process. They're weak all over. But again, it should be symmetrical. Kind of rules out some of the stroke issues. What I have found in a large number of patients in hospitals for long periods of time is they get compression neuropathies. They get ulnar neuropathies with great regularity. They suddenly, have weakness in their hand, and you wonder why that happened. And the answer is their elbows are lying on a bed that's slightly soft, and they've basically compressed their ulnar nerve. If they've got wrist splints in some manner, they may get a carpal tunnel syndrome. Again, it's a function of being in a bed, lying flat for long periods of time. Another one you get is perineal nerve palsies. Now, in your patient, it was difficult to tell. You couldn't tell if she had a foot drop or not, because you've got somebody who's lying in bed. She may or may not, and it's not going to show up as a reflex change. But a perineal nerve injury is when she starts to get up to walk later on, and she's got a foot drop. So you have to consider the potential for compression neuropathy as another major component of being in a hospital bed for way too long. I think all of us, if we've got a really, really good night's sleep, sometimes wake up with a tingling hand. We've slept on our carpal tunnel, or we slept on our ulnar nerve. Goes away in half an hour. These people are on their peripheral nerves for days at a time. They may or may not get turned every 8 hours, and every 8 hours is not enough to prevent getting compression neuropathies. So the take home on the motor exam and the motor complications of COVID are, number one is going to be stroke, and you have to be very, very aware of stroke. Sid pointed out, the Guillain-Barré syndrome, which is relatively rare. Stroke is relatively common. I was looking over the students, and you're talking about some pediatrics. Do pediatric patients get strokes? And the answer is yes, they do. And they get them particularly with COVID. Just be aware, a vasculitic inflammatory process will give you strokes. It'll give you spinal cord strokes. Somebody may have a paraplegia, and you actually have to say, is it a myelitis, which is a possibility, or is it in fact some kind of a vascular complication in the spinal feeding arteries? Strokes don't have to be in the brain. They can be in the spinal cord. So your exam is important. Do they suddenly get areflexic and then later on become hyperreflexic as an evidence of a spinal cord injury? Do they retain bladder control or not? Again, spinal cord injuries are your concern. So we're running low on time. Sid took a lot of time, and I appreciate listening to him.
I'm sorry.
No, I learned more from Sid than you guys will ever know. But so I'm going to turn it back to the rest of the group and point out my main concern on COVID patients, and particularly in hospitalized COVID patients, is strokes. And that's the big takeaway. And you may have to be, sometimes it's subtle, sometimes it's not so subtle. Sometimes you don't know it till you get the tube out and they realize that they're aphasic. You're not going to get a lot of imaging on people in ICU beds. It's really hard to do. So it's a clinical assessment of somebody's acute onset of a focal neurologic deficit in the motor system, which is the easiest one to pick up. Again, the thing to look at, another thing to consider in these people is a visual field defect or visual neglect. Again, you think it's not entirely motor, but it is a stroke syndrome. And you can do that even in hospitalized patients. With that, I'm going to turn it open to questions and other comments.
Thank you so much, Dr. Bernstein. Why don't we start the Q&A with Dr. Good, who will probably have some additional comments and some questions. Dr. Good.
Three comments. One is I appreciated Allan's dog walking in the background. It's a great German Shepherd. That was very nice to see part of our rounds. Secondly, I want to give a comment on youth and age. Tatiana and Solomon and Patricia and Kunli did excellently. They just finished a 4-week rotation on telemedicine. That shows you what medical students can do. I'm very impressed. These are 4 fine young medical students that are going to be great doctors. Secondly, I want to give a compliment on age. Sid, what you presented was excellent. I learned a lot on. And Allan, you're the ultimate Boston practical clinician looking at the patient. All you need is a patient. You don't need slides. You really don't. But it was a very well-balanced, excellent grand rounds. And I thank youth and age. Thank you.
Thank you.
Thank you, Dr. Good.
Thanks,
And,
Jim.
with that, we have about 5 minutes remaining for any questions. You can pose them in the chat, but ideally, just unmute and please pose your questions.
Question. This was sit in for, pardon me, go ahead. Yeah.
Oh, I was just gonna ask, with the incidence of strokes with COVID patients, with comorbidities that increase the issues with COVID, like, are there any specific comorbidities that would increase the incidence of stroke or possibility of stroke in patient, or is it just if they're extremely bedridden, like in the ICU?
It's actually all of the pre-existing stroke risks, which is age, hypertension, diabetes, are the major factors. Cardiac disease, if they have those going into their COVID event, their risk of stroke goes up dramatically.
This is a question. It was remarkable that the word CT was used, brain CT or MRI, because we have really 2 clinicians involved. I found that very refreshing. A very clinical view, look at the patient. And just a question too, do you think we overuse neuroimaging?
To a great extent, yes. Not so much in hospital, it's hard to get imaging. Outpatient imaging is probably overutilized as opposed to just a good exam. I think people think the CT will replace the neuro exam, and that's proved time and time again to be wrong.
Sid, your comment?
Well, actually, I defer to Allan's wise and deep experience, and he's still practicing, and I admire that. Well, in neurology, as Allan would say, there is a certain defensive use of imaging, liability, but when I first became a neurology resident, the CAT scan first came into use. And the pneumoencephalogram was not something you want to undergo. And so I find CT and MRI are useful, but they certainly don't replace a good exam. And you have to use the imaging techniques in the context of the exam and the patient that you're seeing.
Good answers. Thank you.
I have a question for Dr. Kern. Given the benefits of topical remedies and essential oils and so forth, there are quite a number of them that appear to have some benefit for symptomatic relief and addressing syndromes of the neurologic victims, if you will, of COVID-19. What is a practical approach that might be taken to maybe come up with a singular kind of post-COVID-19 cream, if you will, that contains a number of these key elements for those of us who are neophytes in this space? So what's a practical approach that we can take to deliver a solution to our patients?
Well, that's an interesting question. And I don't know that these have been tried, but I would love to see Well, I would, whatever you do, I would add alpha lipoic acid, because particularly these critically ill patients, I think their antioxidant defenses are quite reduced. And so alpha lipoic acid would help restore those. And alpha lipoic acid can be used in a cream form. I think it's available commercially in a cream form. Most of these things I talked about, I wouldn't use a gel. You like something that you can rub on easily, and a cream would be the best. A salve you could use, but a gel would be too firm. And you don't want to just apply the powder. It wouldn't be absorbed. Of the essential oils, probably clove would be an interesting one. My concern, well, the one thing about essential oils, they are so potent that you have to make sure that first of all, you cannot use them directly because they would burn. But if you dilute them in a good proportion, and you could look up the proportion into a cream, I would start with lavender and a small amount of clove. You could actually make a concoction of the 4 of them. And then what else did aloe vera. Aloe vera is, it's used so commonly by people. And you can actually add aloe vera. Aloe vera is 98% water, but you can actually add it to a cream easily. And so what I would do is add some aloe vera to the cream. And so that would be my initial proposal. And if you're interested in doing this, you could call me directly. Jim can give you my cell phone number. I think it would be very interesting, and they're safe. I think it'd be very interesting to apply these topically to these patients. Did I answer your question, Dr. Peckin?
You did. Yeah, right on target. Appreciate that very much.
Yeah.
Well, we're up against the hour a little bit, 1 minute beyond. So we covered a lot of territory. For those of you who have to move on, thank you for attending today. And thank you to our students, our consultants, Dr. Good, and for your support in helping to organize this, and for monthly presentations in this same general category about COVID-19 complications, and hope to see some live patient presentations in the months ahead. So I'll officially close the session. We'll stop the recording, and for those of you who wish to stay on a few more minutes, if you have any